Antiarrhythmics can be confusing, but understanding antiarrhythmic drugs doesn't have to be. In this video, we will simplify this classification, mechanism of action and clinical uses. Vaughan-William classification of antiarrhythmia drugs is based on their mechanism of action. They are classified into Class 1, sodium channel blockers, Class 2, beta blockers, Class 3, potassium channel blockers, Class 4, calcium channel blockers, and Class 5 including miscellaneous drugs. Before jumping into the mechanism of action, if you haven't checked out my video on cardiac action potential, click on the above link. It helps you to understand this much easier. Class 1 drugs block sodium channel. They are further classified into A, B and C, based on their additional properties. In general, Class 1 drugs acts on non-nodal tissues. Class 1A drugs block sodium channel in moderate degree and also has additional action by blocking cardiac potassium channel. Here you see the normal action potential of non-nodal tissue. This is the phase 0 depolarization, phase 1 initial repolarization, phase 2 plateau, phase 3 repolarization and phase 4 resting membrane potential. Class 1A drugs act on the phase 0 as they block the sodium channel. Now we see a reduction in the slope, and this causes slowing of conduction velocity. They also act on phase 3 as they block the potassium channels. This causes delayed repolarization, prolonged action potential duration and prolonged QT interval. It increases the refractory period. As it prolongs QT interval, there is a risk of torsades to points. The drugs belonging to this group are quinidine, procainamide, and disopyramide. Class 1B drugs have weak sodium channel blocking property. They also cause a mild increase in potassium efflux. You must note that it is an increase, not a blockade. So here we see a reduction in slope of phase 0 due to sodium channel blockade. The refractory period and action potential duration both decreases due to mild increase in potassium efflux. The drugs belonging to this group are lidocaine, mexiletine, and toconide. Next is Class 1C. They have a strong sodium channel blockade and no effect on potassium channel. So now we have a decrease in phase 0 slope and no change in refractory period or action potential duration. We must note that, as Class 1C drugs slow the conduction velocity but normal action potential duration, there would be uneven conduction and unidirectional block causing re-entrant circuits. Hence Class 1C drugs are maximum pro-arrhythmogenic. The drugs of this group are flecainide and propafenone. The strength of sodium channel blockade is highest in 1C, moderate in 1A, and least in 1B. Coming to the uses. Quinidine is used in recurrent atrial fibrillation. Procainamide is the drug of choice for Wolff-Parkinson-White syndrome. Lidocaine is used to manage arrhythmias post-myocardial infarction. Class 1C is used rarely in SVT and in life-threatening ventricular arrhythmia. It is contraindicated in structurally abnormal heart. Class 2 drugs are conventional beta blockers. They act on nodal cardiac tissues. Adrenaline and noradrenaline act on beta receptors in the heart and causes sympathetic activity. Beta blockers block this action. These drugs decreases the sympathetic activity on heart. We are now looking at the pacemaker potential. This is the phase for spontaneous depolarization, phase 0 depolarization and phase 3 repolarization. Beta blockers decrease the slope of phase 4 and prolongs the AV repolarization. This increases the PR interval in ECG. These drugs basically decrease the heart rate. The drugs belonging to this class are esmolol, propranolol and metoprolol. They are used to treat SVT, for rate control in atrial fibrillation, ventricular arrhythmia post-myocardial infarction and in emergency rate control. Class 3 agents are potassium channel blockers. They act on non-nodal tissues. They act on the phase 3 of action potential and increases the action potential duration, increases the QT interval and has risk of torsades to points. Drugs belonging to this class are amiodarone, dronedarone, ibutylide, dofetilide, and sotalol. These drugs except amiodarone have reverse use-dependent prolongation of action potential. This means that these drugs prolong action potential duration more pronounced at lower heart rates than higher heart rates. The mechanism underlying is that potassium channels are more open during rapid heart rates and less open during slow rates. Since the drug binds better when channels are in the closed state, blockade is greater at slower rates, causing more prolonged APD and QT interval. Amiodarone, in addition to potassium channel blockade, it also has beta blocker, sodium channel blocker and calcium channel blocking activity. Sotalol has both beta blocking and potassium channel blocking activity. Ibutylide is a structural analog of sotalol but lacks the additional beta blocking ability. Amiodarone has the widest antiarrhythmic spectrum. It is used in refractory VT and VF, in acute myocardial infarction, atrial fibrillation, and all arrhythmias except torsades de pointes. The side effects of amiodarone are hyperthyroidism, as it contains 37% of iodine. Hyperthyroidism due to inhibition of peripheral conversion of T4 to T3. Peripheral neuropathy, pulmonary fibrosis, hepatotoxicity, photosensitivity and corneal microdeposits. Class 4 agents are L-type voltage-gated calcium channel blockers. They act on nodal tissues. Here it decreases the slope of phase 0 and decreases the automaticity and conduction velocity. The drugs belonging to this group include verapamil and diltiazem. These drugs are used to treat PSVT and to control ventricular rate in atrial fibrillation and flutter. Class 5 antiarrhythmic agents include drugs like digoxin, adenosine, magnesium and atropine. Let's have a quick recap. Class 1 and 3 act on non-nodal tissue and Class 2 and 4 act on nodal tissue. Class 1 are sodium channel blockers and they decrease the slope of phase 0. Class 2 are beta blockers and they decrease the slope of phase 4 in pacemaker potential. Class 3 are potassium channel blockers and increases the phase 3 duration. Class 4 are calcium channel blockers and they increase the slope of phase 0 in pacemaker potential. Class 1 has 3 subclass. 1A has additional potassium channel blocking activity. So increased action potential duration and refractory period. Examples are quinidine and procainamide. 1B has additional potassium efflux increasing effect. So decreased refractory period and action potential duration. Examples are lidocaine and mexiletin. 1C has no additional activity. Examples are flecainide and propafenone. 1C blocks sodium channel more stronger than 1A while 1B is the least. Class 2 included esmolol, metoprolol and propranolol and are used to lower heart rates. Class 3 agents prolong the refractory period and action potential duration. Examples are amiodarone, dronedarone and sotalol. Amiodarone has widest antiarrhythmic spectrum and used in all arrhythmias except torsades de pointes. Class 4 decreases the automaticity and conduction velocity. Examples are verapamil and diltiazem. Used in PSVT and rate control of atrial fibrillation and flutter. Thanks for watching. Please do like, share and subscribe for more videos.